This is the C-spine. The views taken are AP, open mouth, lateral, and obliques. And the site-specific routine views are the same. This is the AP. It's 40 SID and 70 to 80 kV range for analog and 75 to 85 for digital systems. The patient is either supine or erect position with the arms by the side. The part position is to align the mid-sagittal plane to the CR and midline of the table and or IR. Adjust the head so that the line from the lower margin of the incisors to the base of the skull is perpendicular to the table and or IR. Line up the tip of the mandible to the base of the skull, should be parallel and angled to the CR. Ensure no rotation of the head or thorax exists. The CR is angled 15 to 20 degrees cephalad and directed at the level of C4. So the evaluation criteria: anatomy demonstrated, C3 to T2 vertebral bodies, space between pedicles and intervertebral disc spaces clearly seen, no rotation indicated by spinous processes and sternoclavicular joints equidistant from the spinal column lateral borders. The mandible and the base of the skull should superimpose the first two cervical vertebrae and collimate to the area of interest. Here you can see some points of anatomy. For the open mouth, the SID is 40 and it's 70 to 80 kV range for analog and 75 to 85 kV for digital. Position the patient in the supine or erect position with arms by the sides. Place the head on a table surface, providing immobilization if needed. Align the mid-sagittal plane of the central ray and midline of the table. Adjust the head so that with open mouth, a line from lower margin of upper incisors to the base of the skull is perpendicular to the table. Ensure that the mouth is wide open during exposure. Do this as the last step and work quickly because it is difficult to maintain this position. Direct the CR through the center of the open mouth. For evaluation criteria, the dens and the vertebral body of C2, lateral masses and transverse processes of C1, and atlanteoaxial joints demonstrated through the open mouth. The optimal flexion extension of the neck indicated by superimposition of the lower margin of the upper incisors on the base of the skull. Neither the teeth nor the skull base should superimpose the dens. If the teeth are superimposed on the upper dens, reposition by slightly hyperextension of the neck or angulation of the CR slightly cephalic. Suspend respiration and collimate to the area of interest. Here are the 5 points of anatomy. For the lateral position, the SID is 72 inches and the kV for analog is 70 to 80 and 75 to 85 for digital systems. Position the patient in the erect lateral position, either sitting or standing, with shoulders against vertical IR. Align the midcoronal plane to the CR and midline of the table and or IR. Center IR to CR, which should place top of IR about 1 to 2 inches above the EAM. Ask patients to relax and drop shoulders down and forward as far as possible. Direct the CR horizontally to C4. For the evaluation criteria, the cervical vertebral bodies, intervertebral joint spaces, articular pillars, spinous processes, and zygapophyseal joints are seen. C1 through C7 through T1 intervertebral joint spaces are clearly seen. If upper margin of T1 is not demonstrated, additional images such as the cerviothoracic lateral should be obtained. The rami of the mandible do not superimpose C1 to C2. The right and left articular pillars and zygapophyseal joints should be superimposed for each vertebrae. The body should be free of superimposition of the articular pillars and the spinous processes seen in profile. Collimate to the area of interest. Suspend respiration on full expiration. Here you can see some anatomy. For the oblique position, the SID is 72 inches and it's 70 to 80 kV for analog and 75 to 85 for digital. For the patient position, the erect position is preferred, sitting or standing. but recumbent position is possible if the patient's condition requires. Align the mid-sagittal plane to the CR and midline of the table and/or IR. Place patient's arm at side. If patient is recumbent, place arms as needed to help maintain position. Rotate the body and head into 45 oblique position. For the anterior oblique, direct the CR 15 degrees caudate to C4, and for the posterior oblique, direct the CR 15 degrees cephalad to C4. Suspend respiration and collimate to area of interest. For the evaluation criteria for the anterior oblique, intervertebral foramina and pedicles on the side of the patient closest to the IR. Posterior oblique, the intervertebral foramina and pedicles on the side of the patient farthest away from the IR. The intervertebral disc spaces and intervertebral foramina of interest C2 through C7 should be open and uniform in size and shape. The pedicles of interest should be demonstrated in full profile, and the opposite on-end pedicles should be aligned along the anterior cervical body. On-end pedicles aligned at the midline of their cervical body and visualization of the zygapophyseal joints indicate over-rotation. Obscure intervertebral foramina and pedicles indicate under-rotation. The mandibular rami should not superimpose the upper cervical vertebrae, and at the base of the skull should not superimpose C1. Here are some points of anatomy. I did not see any pathology. The only correction I would make would be to collimate a little bit more on some of the views, and the patient was shielded.